Raweh from Klinikum Dortmund, Germany. In our study, we wanted to see if there is a difference between the Resect approach and the Resect approach in mitral valve repair in producing postoperative systolic anterior motion. In the Resect approach, triangular or quadrangular resection are used, and this decreases the height of the coaptation and increases the residual part of the anterior mitral leaflet. On the other hand, the Resect approach uses shortened new codi to displace the posterior mitral leaflet and pull it down into the left ventricle. And this increases the height of coaptation and decreases the residual portion of the anterior leaflet. Between July 2015 and March 2020, a total of 222 patients received mitral valve repair, and we studied the echocardiography of these patients. Systolic anterior motion has risk factors. If the patient had two major risk factors, or one major risk factor and two minor risk factors, he was considered high risk for postoperative SAM. In our study, 222 patients had mitral valve repair. 199 patients received the Resect approach, and among them, 8 patients had postoperative SAM. On the other group, 23 patients received the Resect approach, and only 1 patient had postoperative SAM. The p-value was 0.46. There was no significant difference between both groups. It's also important to say that the length of the free edge of the anterior mitral leaflet creates the residual portion of the anterior leaflet. And this part of the anterior mitral leaflet, if it's free without coaptation, might play an important role in producing postoperative systolic anterior motion in both groups, the Resect and the Resect group. And further studies are needed in this direction. Thank you very much.
Hi, Dr. Raweh. Thank you for this presentation. There is very different groups. We have one big group and the other one is a small group, so it's difficult to get a real answer on your comparison between resection or not. And do you use Gore-Tex in addition to your repair or not?
Yes, we use Gore-Tex. When we use Resect approach, we use the Gore-Tex new codi for the repair.
And how do you size the codi?
Actually, we use it intraoperatively. We use the water method. We do it with water test, and then we move the new codi up or down until we get a good result.
Yes, and during the original presentation by Patrick Perrier for this Resect rather than Resect publication, he used to add a suture of the indentation between P1 and P2 and between P2 and P3 in addition to the chordae placement. So did you do that? Did you close the indentation or not in your technique?
Yes, when it's needed, when there's an indentation, we close it.
Okay.
So it's the closer of indentation is also used in the Resect group. And the major difference in the Resect group was the resection of the leaflet. In the other method with Respect, we try to leave the leaflet without resection. And if there is an indentation, we close it.
Okay, because I think that if you close the indentation, you have a smoother posterior leaflet, so that the risk of SAM is probably decreased, whatever you do with the Gore-Tex. So now, after your experience, when do you decide to resect or not? Do you have a recommendation for that? Which patient? Well, okay.
Yeah, actually, this was a retrospective study, so it was up to the surgeon to choose which method he prefers. But as you can see in our study, the major number of patients were in the Respect group. So we've done most of them in the Respect method. And the surgeon decided in each case, because it was a retrospective surgery.
Okay, but now you have some experience. You have presented many patients. So, in which patient we have understood that the resection Respect is your preferred technique, and this is a trend for almost every team right now. But in your institution and after your experience, in which case do you still resect tissue?
Now, with our experience after many years, currently we prefer the Respect method, because we try to preserve the posterior leaflet as much as we can, so that we have a smooth surface for coaptation, and so that we have a height and enough height for the coaptation. Sometimes you have to do a resection if the posterior leaflet is really large. It's above 2.5 centimeters, for example, and the anterior leaflet is also very large, above 3 centimeters. And you try with pulling the posterior leaflet down, and you find that it's still not enough. So sometimes you'll have to use the resection.
Okay, thank you.
It's not that we are against resection or something like this. It's just we do more Respect at this moment in time.
Okay, one last question. There are two kinds of resection. Either you do a quadrangular resection, larger or not, more. And you also can resect the height of the posterior leaflet. I mean, with a sliding suture. And you resect a triangle. You have a triangular resection on both sides of your quadrangular resection, so that you decrease the height of the posterior leaflet. And it is perfectly well known that the height of the posterior leaflet is a real risk factor for SAM. So do you also do those sliding plasty with a resection of a part of the height of the posterior leaflet?
No, actually, we didn't use the sliding technique. We used only the triangular, and in very rare cases, the rectangular, quadrangular resection. But the sliding technique was not used in this patient groups. And what I want to say is that the important thing that we wanted to notice is how much can we decrease from the free edge of the anterior mitral leaflet. Because if you have, even if you resect the posterior leaflet and you pull the anterior leaflet or the coaptation point posteriorly posteriorly, and you still have long free edge in the anterior leaflet, you can get SAM.
Okay, thank you. I think now it's time. It was a little bit confusing during this session with a different speaker. We have to apologize for that, but it is probably the experience which has to go up with new kind of meetings. Thank you, Dr. Raweh, and all the other speakers, and congratulations again for your expertise and for sharing this experience with us. Goodbye, everybody. Now.
Thank you.